Welcome to VLU, Vein and Lymphatic University Grand Rounds. It's my pleasure to host this session. And today we are going to be talking about thermal complications, how to avoid, and what to look for. And it's my great pleasure to introduce Omar Esponda, who I have gone back many, many years with, and he's a great physician. He's a vascular medicine physician as well, actively in practice in North Carolina, and also our discussants, Dimitrios Kanathanasis, who I've known for many, many years, as well as Evgeny Shadikov. So, Omar, the floor is yours. By the way, while his PowerPoint's coming up, we are all live also on YouTube.
Hello, pleasure to be here. Can you see the meeting?
Yes.
The slides? Excellent. Well, pleasure to be here. My name is Omar Esponda, and let's begin. So we'll focus on three main issues here: endothermal heat-induced thrombosis, nerve injury, and skin burns. Presentation will follow definitions, incidence, and risk factors, prevention strategies, and management approaches. Endothermal heat-induced thrombosis was first described by Dr. Lowell Kapnick in 2006. That happens almost 20 years ago. And it was described as a post-treatment clinical entity resulting from thermally ablating a superficial trunk and thrombus extension to the adjacent deep vein at the junction. And EHIT is divided into four classes, and its classification determines severity and a treatment pathway. As a post-treatment clinical entity is usually screened between 72 hours and 1 week post-procedures. To decrease the risk of EHIT, the heating element should be at least 2.5 centimeters or more away from the junction. Other important risk factors would be a large great saphenous vein or small saphenous vein, and there are other possible contributors to EHIT, such as prior thromboembolic events, male sex, older age. However, most of these are reported based on retrospective data. As an example, you'll see here a geriatric age patient with advanced symptomatic chronic venous insufficiency and enlarged GSV at the saphenofemoral junction. At RFA, due to the tortuosity of the truncal vein, the heating element could only be positioned at 4 centimeters away from the saphenofemoral junction, which is more than the recommended distance. 48 hours later, at follow-up with ultrasound, you can see thrombus extension that protrudes into the deep vein, occupying more than 50% of the venous lumen, requiring anticoagulation. However, 1 week after therapeutic anticoagulation, we saw resolution of thrombus extension into the deep vein and retraction of the thrombus. Consequently, anticoagulation was stopped. EHIT classification in class 1, there's no thrombus propagation into the vein, so there's no surveillance or anticoagulation required. In class 2, the thrombus extends into the deep vein, but it occupies less than 50% of the lumen. Therefore, based on risk, you could start antiplatelet therapy or a treatment strategy with anticoagulation and follow up in a week. In class 3, as I showed you recently, is just occupying more than 50% and anticoagulation is required. In addition to class 3, class 4 basically is treated as a acute DVT. And typically this happens it's a low incidence of 0 to 3% it happens in cases and it's usually asymptomatic. Now, when it comes to nerve injury, the risk is anatomically. In approximately 90% of the cases, the sural nerves lies within 5 millimeters of the small saphenous vein in the distal 2/3 of the calf. And deep fascia is usually absent, and ablation in this region carries a high risk of sural nerve injury, which can result in sensory deficits or neuropathic pain. In the proximal third of the calf, deep fascia is present in more than 95% of the cases, providing a protected layer between the SSV and the sural nerve, and this is the preferred access point. In the rare occasion, the tibial nerve can be less than 1 millimeter from the small saphenous vein over short defined segments near the saphenopopliteal junction. And if you're there, it is very likely that you are going to injure the tibial nerve, though most people don't get that close into the junction. So you see here how the proximity of the sural nerve to the small saphenous vein varies significantly over the path from the lateral malleolus to the tibial plateau due to the anatomic variability and the presence of an absence of the fascial layer. See the nerve down. The saphenous nerve crosses and adheres to the great saphenous vein in the distal third of the leg in more than 55% the cases or so. This close anatomical relationship, it creates a vulnerable zone. And any thermal energy applied here will risks direct nerve injury. However, in clinical series, paresthesia rates are reported to be around 4%. And usually these problems are transient following 4 weeks post-procedure. You'll see to prevent injury to the saphenous nerve, the access point for thermal ablation should be above the surface point, roughly at the tibia plateau or above. Here, a 45-year-old woman presents with leg numbness, tingling sensation, and she reports anteromedial numbness and tenderness 19 days after RFA. See that the access point was located at mid-calf. 6 weeks after thermal ablation, the patient reports continued improvement with from the numbness, and see here at the ultrasound the proximity of the nerve to the GSV at mid-calf. To prevent nerve injury, we use tumescent anesthesia, so to physically separate the nerve and surrounding tissues from the vein when appropriate. This creates a protective buffer and provides a heat sink during energy delivery. We should use 2 planes of visualization: the longitudinal sidal view, which confirms the catheter positioning along the vein and ensures continued fluid halo. And of course, the short view, the transverse view, when one would verify the circumferential distribution of the tumescent fluid along the catheter. Understand that superficial trunks and inadequate tumescent can increase the chance of skin burns, and you should maintain a safe distance between skin and vein, particularly at the calf. It would be wise to limit the energy to reduce the thermal spread at the below the knee, and whenever you are able to, consider non-thermal alternatives in vulnerable areas such as the distal calf or epiphyseal veins. Take-home checklist really here is stay away from the junction at least 2.5 centimeters, surveillance 3 to 7 days to detect EHIT, avoid the distal 2/3 to avoid injury to the sural nerve, consider non-thermal alternatives for the GSV below the knee. Remember to tumescent in 2 planes and avoid energy too much at the calf. That's pretty much it for my end, guys.
Thank you very much. Of course, there are more um, uh, complications than you mentioned. And the first one I'm going to mention to you is the creation of an AV fistula that occurs very sporadically. Have you seen that?
Well, thankfully I haven't, but it has been reported in at least 2 articles, and particularly one of yours from NYU, a quite long time ago.
What do you think about those?
Well, if I were to think about it in terms of why it might happen, I would say that maybe the heating device would be too close to the artery, and tumescent anesthesia might have been deficient, so to speak, and as a reason, the injury developed, it would have then created a pathway in between the artery and the vein.
So, good explanation. I wasn't smart enough to come up with the concept, but as you know, we're creating fistulas now using a percutaneous with a thermal device that connects the artery and vein. And if only I was smart enough, I could have probably figured that out. But the other thing I think you hit on is maybe a tumescent needle stick. And as you know, it's the pudendal artery that runs underneath the great saphenous vein. Now, there are other issues, but I'm going to turn it over now to Evgeny Shadikov to comment or ask questions.
Yes, thank you, Lowell. Thank you very much for your invitation. And Amar, thank you very much for a very interesting topic. Thank you for this meeting. We met before with you in one of the American Venous Forum and discussed about the same topic, I remember. Thank you for the extremely relevant and useful presentation for everyday clinical practice. Regarding the treatment and management of a heat, there is some clarity. And thanks, Lowell, for his recommendation and some remarks from Peter Levitsky. Of course, it's a very important topic. But not about the same about the prevention. Unfortunately, we face certain difficulties in matter of prevention. This is especially true for young surgeons who don't have sufficient surgical experience. So I would like to ask you some questions, and I would like to know your opinion on three things. Maybe they are very simple, but very important from, I think. The first one, based off your experience, is there difference in the incident of a heat after laser or and radio frequency? The second one, with a larger diameter of gray saphenous vein, is there dependent between the incidence of a heat and the degree of thrombus propagation on the number of radiofrequency cycles? And the third one, could a heat be simple and inadequately performed tumescent? Maybe all our problems with the heat, it's not adequate tumescent anesthesia and adequate anesthesia, and the results of our operation depend of quality of anesthesia. There is no doubt that knowledge of anatomy allows us to prevent damage of superficial nerves during thermal procedures in most cases. Mini phlebectomy or microphlebectomy, especially on the lower leg, is much more dangerous. I think so. And finally, thermal burns. Last question. Do you have your own experience with the porcupine type of surgery? Does not this technique increase the risk of burns and nerve damage? Perhaps we should listen to Peter Glavitsky recommendation. I'm reading now. Peter Glavitsky, prefer non-thermal for very superficial segments to avoid skin nerve injury. Peter Glavitsky, 2024. Thank you very much.
Thank you, Evgeny. Omar.
I think I heard about 5 questions there. However, I'm going to capture the gist of it. I'm not aware of there being a higher risk of EHIT when it is used EVLT or RFA. I don't know if there's actually a difference between the two. That's one thing. The other thing is that what can play into developing an EHIT. I guess we said something about like the distance of it, but then the ablation device from the junction. But if you actually see the case that I discussed, I was 4 centimeters away from the junction. However, what I believe what played the part in developing the thrombus extension really was the large circumferential vein that we had. It was like over 1 centimeter. And of course, the clot that develops after EHIT appears to be histologically different from what we would call a garden variety deep vein thrombosis. And recently, I mean, Parsi mentioned something about the qualities of the thrombus. However, in the setting of sclerotherapy, which gives us food for thought in how is it that a thrombus develop after injury that we create as we try to treat the great saphenous vein or the small saphenous vein for that matter. I'm not sure I answer all 5 questions, but that's my best approach to your question, sir.
Porcupine type of surgery. Your
Oh,
experience.
the porcupine, I have absolutely no experience with the porcupine. As a matter of fact, that's why I included the Guimaraes article in the talk. I'm particularly interested. And as Glovisky would describe in earlier, right, you could go below the knee at mid-calf, right? But Guimaraes is actually going even down further with the porcupine technique. So it appears to be a matter or how much energy you apply to the vein and the heat spread that happens depending on the amount of energy that you apply. So it looks to be reasonable.
So, as you know, Evgeny, there are pockets of people doing the porcupine technique, which for those people that are on is to ablate every vein using laser at this point. And there are some really great reports. I'm going to answer these questions really quickly, and then I've got to turn it over to Dimitrios. Do you use prophylactic anticoagulation uh, uh, after EVLA based on, if you do, what score do you use? And this is Dr. Jacko asking this question.
Um, Truth be told, I seldom use the Caprini score prior to an ablation. And on occasion, depending on patient's history, when it comes to prior venous thrombosis, body weight, like a high BMI, and prior history, size of vein, and BMI sometimes triggers me into recommending prophylactic anticoagulation after a procedure
So
without waiting for the ultrasound.
So, in the UK, they give prophylactic, and they give DOACs or low molecular weight heparin almost routinely. In Russia, Evgeny, do they do that? And then Dimitrios answer after Evgeny.
Usually no, we don't have this recommendation, but sometimes in different private clinics they use it, lower molecular heparins, but it's not a rule.
Dimitrios?
Single shot anticoagulating of prophylaxis with low molecular weight heparin, and the day after ultrasound. This is our policy in Italy. You need to do this also for medical legal reasons because they are very strict in Italy. I know it's not science, Lowell, but we have also to keep our mind on this because they decide for our lives. And
I understand.
then for all people with thrombophilia, major or minor, that had prior thrombosis, so for all of them, 7 days prophylaxis.
So I think that we're probably all in agreement for those high-risk patients to prophylax, but for the routine, no, I don't think so. Dimitrios, the floor is yours.
Thank you, Omar. Great presentation. I think you reached every hot topic on complications. I didn't see a major complication. It's not so bad, but it is cost effective. The name is persistent patency of the ablated vein. And I think it is one of the complications of endothermal ablation techniques. And in the literature, you can find that it rises up to 12% after the ablation and inside 2 or 3 months when you follow up the patient. So What do you do for these patients when you see recanalization? You follow up them. If they are symptomatic, you treat them immediately. If they are symptomatic, but you have, big veins again, you didn't close the vein, you have a total recanalization, what do you do? And then how you manage elder people that are doing anticoagulating therapy. Many of the new anticoagulants are normal use. You can suspend the anticoagulation therapy for 1 day, nothing wrong with this, but how you manage this patient? You do phlebectomies at the same site with the thermal ablation or not? The last thing, probably it is my opinion, there is no data on this, but I really like to do flash ablation to the inferior epigastric vein, not to the femoral vein, as many authors, there are many authors that like flash to the femoral vein to ablate this vein. And we all know that the FDA rules are, to make these techniques more safe. So the 2.5 centimeter, is it your policy or it is because of the FDA techniques? Because I'm flashing to the inferior epigastric vein, and I see no difference between 2.5 centimeters or else.
So, first, when it comes to technical success as a measure of closure, for example, status post ablation at 48 hours, at 72 hours, at a week status post ablation, usually is the case that we don't see failure of, as in recanalization, right? Sometimes it is the case that maybe at 3 months' time at follow-up, you may see recanalization. However, we don't necessarily deem that to be a failure, because although we measure technical success as closure, right? The reason why we're doing this, okay, is for symptomatic relief of venous hypertension. And it is often the case that you may have a recanalized vein. However, for some random reason, it no longer is refluxing, right? So imagine that. If the patient has improved scores for quality of life, improved scores in the C classification, and improved scores in the VCSS, we deem that to be a clinical success. So we really don't pursue that until, meaning reintervention, unless the patient is clinically symptomatic for a reason. When it comes to patients that are in anticoagulation, probably those are my favorite patients. I do not discontinue them from anticoagulation. As a matter of fact, and proudly so, there are two studies from NYU. One was done with warfarin, and effectiveness of ablation, and it has no
Correct.
it doesn't
No
harm the
difference.
patient. There's no difference. That was with warfarin, and then later on, it happened with DOAC. It's the same thing. However, I'm a little bit cautious when it comes to patients that need phlebectomy as well. But because they're already anticoagulated, my pathway with them really is I go through the truncal vein first, and because it's unlikely that those veins are going to spontaneously thrombose because the patient is in anticoagulation, I give them some time for the varicose burden to maybe diminish. And at a later point, if so it's needed, then I'll approach it either with phlebectomy or with ultrasound-guided sclerotherapy. In regards to, so I don't really discontinue patients most often from anticoagulation. And in regards to the approach to the epigastric vein, the flash ablation to it, as in Dr. Kavanagh was saying, our colleagues in Europe across the pond do prophylactic anticoagulation, but bear in mind that basically most often they take the ablative device up to the saphenofemoral junction. They don't really mind going away from the junction. But if you even think more of it, the IFU, for example, the instructions for use of some of these devices, particularly the RFA, say that we should be at a distance of at least 2 centimeters. The reason it makes sense, 2.5 centimeters and above, then again, there's a study at NYU that after a series of patients, it looked like the magic number to prevention of EHIT might be between 2.5 and 2.7 centimeters away from the junction.
Okay. Do you believe also that the diameter of a vein is a risk factor for EHIT? You said more than 7 to 10 millimeters, it's a risk factor. So what you're going to do for big veins, about 20, 25 millimeters? You will never ablate them?
No. I mean, I do go
Or
about
you will anticoagulate them?
No, I do go about and ablate those veins when I can. There's a discussion that I have to have a patient, because what happens is that patient may have a lump in place at the inguinal area where that is the case. But so it is that in time, the vein is most often continues to be closed and decreases in size. So sometimes it really is a matter of patience after an ablation.
I'm going to jump in here for a moment and ask Omar and the panel. When we talk about EHIT, does anybody really care right now about an EHIT-2? Do you really need to anticoagulate an EHIT-2? And are the majority of EHITs that you see EHIT-2? Omar, take it.
I would say that the majority of EHITs that I see are EHIT-1. Which is, I pat myself on the back every time I see one, because that would be the perfect closure, right? Otherwise, yes, when we see EHIT-2, depending on patient's preference, I may advise for antiplatelet therapy. I may advise for prophylactic anticoagulation strategy, or I may just say, why don't we just see this in a week and
Okay.
let's see what happens. It really is a discussions between patient and physician and patient's preference, and that's the way to go, I believe.
Evgeny, your opinion?
I'm agree with Amar. The same situation. Usually, I recommend anticoagulant therapy HIT too, and 1 week control, ultrasound control.
Thank you. Demetrios?
Yes, for EHIT-2, I think that we have to anticoagulate and see the week after how the patient is going on. If you see flow in the epigastric vein, that's it. I will stop everything. For 3 and 4, I think, yes, it is mandatory to do this. For 1, nothing to do. I think if you will wait, you will see the retraction of the stable thrombus, as Omar said. We have many histological specimens of this thrombus, and we know that there are no inflammatory cells inside. It is really stable, but it's something that, happens and just go back again in a week or 15 days.
So we know historically that most of these EHIT-2 thrombus disappear within 14 to 21 days. We know that the thrombus burden is not a lot. We do know that there can be a pulmonary embolism from a small EHIT-2. However, most of those are asymptomatic. And this is kind of my feeling that the majority of EHIT-2s, I do not anticoagulate unless they have some risk stratification. But I think it's very easy now to anticoagulate somebody with DOACs and have them take it. But you should be repeating your ultrasound within a week or two to see if the thrombus is retracted. You should measure that in an upright position as opposed to a recumbent position. And I will stop there because we have 1 minute left. I want to thank everybody here. It was wonderful. We could go on and on this, and we might have complications too, but we'll probably shift into non-thermal complications as well. And next week, we are going to be talking about Varithena, which is a proprietary foam used in the United States, when to use and when not to use. Dr. Mark Meisner will be presenting that, and Todd Jones and Masaki Koguchi will be the discussants. So with that in mind, thank you everybody for joining. We appreciate it, and have a good day.
Bye-bye.
Bye. Thank you so much.
Bye.
Bye.